So I had this patient, right, and she had one of these hurt shoulders. She had a scapula, and she had a whole arm and stuff. She had one of these hurt shoulders. One of these hurt shoulders actually go all the way up into the neck. So it was all twanging off right about there. Now, with that, though, of course, it's never ending, this stuff. With that, there was a posterior rib, and that posterior rib was at about T6. So there's your sixth thoracic, in and about there. And when we say posterior, we mean it's like it's coming back at you from this posterior view here, as if it were being pulled back. In any case, because of the fact that we have a dorsal scapular nerve, DSN, which happens to come from the neck, incidentally, and travels down this way to innervate the rhomboids, which certainly aren't pink, but I do love that color. This creates a bit of a point of tension, or a bit of a point of pressure. And even though it won't hurt the nerve directly, this rhomboid scapula rib point will create enough irritation to cause some problems. So that makes a bit of sense. And now the shoulder makes sense, but as well, it makes sense out of the neck being in pain, because that neck has crossing over innervation. It shares the same nerves with that dorsal scapular area. So it's a nice point of referral. Done? No, of course not. That's ridiculous. Why is that rib in that position? Now, when it comes to rib vertebra stuff, the rib and the vertebra follow each other. So in this case, that sixth thoracic segment was rotated, pointing towards the right. We call that a right rotation. It means that the transverse process to which the rib attaches in and around that area is back at us. It is rotated towards us, back on that right side. Now, that being the case, this vertebra tends to, with right rotation, side bend to the left. So we're going to see a bending to one side and a rotation to the opposite side. And this is normal. So it's pulling that rib back. It's changing the space in here. Not done. Of course not done. That's ridiculous. This vertebra happened simply to be at the apex of a greater curvature. There was a left side bend, a bend to this side. It was short on this side. And it just so happened that at about that T5, 6, 7, 5, 6, 7 area, and that it was the most bent. We call that an apex of that curvature. And it was being pulled down on that left side. And at that point, that was where we saw the most rotation, the most side bending of the vertebrae. Done? No. Why? Ever? There's got to be something pulling that down. That left side bend has to be created by something. And that can be seen as simply as the myofascial tissues that happen to attach to that area. Looking at it from the front, because that's just a better view, if you had your xiphoid process here, and you had your hips, innominates, pubic symphysis, which we say for a reason, of course, sacrum, and lumbar spine within here, there was on that left side a pull towards this direction. We would call this, of course, our oblique tissues, which fuse into the inguinal ligament, which attach here. So that oblique was generally pulling down towards the left, creating both side bending rotation simultaneously. And this is not abnormal, but there's, of course, more to that story. It never ends, it never ends. We could take this all the way into the leg if you wanted to, but trust me, you don't want to. So what was doing that? So to pull on that oblique tissue, we need a rotation around a transverse axis, and we can get that quite easily from the innominate being down at the pubic symphysis and being anteriorly rotated on that left side to generate a pull through that oblique tissue like that, which pulls on the rib cage into a left side bend, which forces a vertebrae at the apex of that curve to rotate right, which changes the position of a rib, which changes the position of the shoulder and the rhomboids and irritates stuff in that area, creating, I don't know, shoulder pain, probably. That's a mess. Simple Lines Anatomy. Good luck with everything.